I'm so glad I said camo today because I knew you were just going to eat it up.
Are we recording right now?
Yeah.
I make a request that we put Fred Bear on the intro. Fred Bear. Is mine spicy?
Mitch, throw down a beat.
The chattering squirrel.
We're going to talk about...
We just have camo. We just have our camo day.
Okay, that's
it. That's a wrap.
We're done.
Thanks for watching.
Thanks, guys.
That's a wrap. Welcome again, family and friends, to another episode of Spinal Tap.
This is the house of learned doctors. You're not a doctor.
The moment is about to meet his test. And here it comes.
12 points and a 50-inch spread.
Fred's got to get within 50 yards to make his shot good.
Antlers this size make camp history.
This is our camo episode.
Resource tap here.
The outdoor camo episode.
We're hunting for answers.
We're...
Hunting for solutions. I
Does
don't know
that
what
get any
means.
bigger, or does it just say that
No,
size?
it's broken to that size.
It's taped together.
It's never actually fit my head properly. Now we need to change into our lab coats.
Myself, Zach Mashinsky.
Mitch Everson.
Richie man, I guess.
We're going to talk about some non-surgical spinal decompression,
Yeah.
also known as decompression.
Did we also want to talk about, like, this?
The trifecta.
The flux
triangle,
capacitor,
the flux
is my
capacitor.
favorite
Our
one.
intentions
By far.
with this new endeavor.
Yeah,
Yeah, we
like
talk about that.
how
Yeah.
the whole thing...
How it integrates,
Yes.
how it works together.
Yeah.
Yeah, because I mean, it's all important because it's kind of like, whenever we buy new technology, it's like, is it going to help our patients?
Yeah.
It's like number one question.
Do you want to explain how this applies to a flux capacitor? These 3 points that make
It's
the
got
strongest...
3 points. So
It's a triangle.
it's the inside of a triangle, maybe.
A circle.
So we'll put a graphic up here. Pretend that this is the flux capacitor.
Not Illuminati.
Not the Illuminati. And what are the 3 points?
Adjustments
Yeah.
to help get motion in segments of the spine or other joints that aren't moving is number one. Because you can promote better motion, that helps with surrounding areas of the disc, the nerves, the muscles, the ligaments, the tendons. And then SoftWave, like Dr. Mitch was saying, if we can increase blood flow, decrease inflammation, that's going to decrease pain, but also help a regenerative process of activating stem cells, starting to heal that tissue on a cellular level. And then decompression are more for cases where... Well, on that poster behind you, like where those yellow nerves are coming out of, those holes where they come out of, those should be nice and wide, and they can be decreased in size for a number of reasons: disc herniation, bulges, stenosis, facet encroachment, degeneration, things like that, like people think of. But ultimately, what the decompression does is it decreases.
It decompresses.
It decompresses.
Slow down.
Yeah, crazy, right? It decompresses, but it gives space of the discs and the holes, and more on a physiological. It creates a negative pressure in the disc, so that can start to bring in a herniation or a bulge, or at least gives the potential for it to happen because it creates that negative vacuum, that negative pressure.
Yeah.
That can bring it back in, but while it does that, it also brings in nutrients and
That
blood
was
flow.
my question, yeah.
Right?
Yeah.
So it can, there's a lot of good like videos on like, good diagrams of like how it works and what it does, but it's creating that negative osmotic pressure so that it can bring in some nutrients.
So,
kind of like a dried out sponge.
So
right?
then,
like,
does how often does that decompression, that openness have to last in order for effects to kind of take place? Because in a naive person to be like, well, you get off the table, now it just goes back to its original state, right? But how does it actually work?
Yeah. So there's protocols on it, and it depends. It all kind of is based off the exam, right? So when somebody comes in, it's like going over a full history, doing exams, doing orthopedic tests to rule in or rule out like if they're a good candidate or not. A lot of times, and even some practices require like imaging, like a MRI or a X-ray to like show exactly what's going on with the disc if there is a herniation or bulge.
Helps identify the level 2.
The level 2, yeah, because it could be in many areas. There's more more commonly happens in the low back, like the lower part of the lumbar spine. So like L4, L5, L5S1, like those areas are more common.
Why is that?
Probably because of a few factors. Number one, that's where most of the load is happening on your spine. And your discs are pretty cool. Like as they go down your spine, they typically get bigger because they're bearing more load.
Sure, like a water tower.
Like a water tower, yeah. But also a lot of the common things is like postural changes or too much flexion, right? So like sitting puts us in flexion, right? But improper lifting, like if people are using their backs more than like a hip hinge, like that over time puts wear and tear on that disc, and that's just a common spot where it occurs.
Yeah, and so SoftWave isn't something new to the clinic and you guys, and then decompression, you both have had experience with it in the past in other clinics.
Yeah,
and found it to be something that was.
Yeah, it's definitely a tool in the toolbox.
Yeah.
We just didn't have the capacity when we bought the practice to bring it on, and there are some clinics that are completely dedicated to decompression, where it's like new patients are most likely getting on decompression for a certain amount of time.
Yeah.
I don't think we're gonna make that choice. You know, some people are like, yeah, you got to be 100% committed to decompression in your clinic, but I think we're gonna filter it in as we need to.
And there must be some like certain frequency of decompression that you'd have to do to get the results, right? It's not a one and done situation.
Right. So there's treatment protocols, and like I said, it kind of starts with the exam, but somebody might, like if they're really acute and they have like a pinched nerve or a hot disc, like a fresh disc, they very well could be coming in every day for the first couple of weeks, like depending on the severity. Some people recommend that until they're 50% or better and then drop down frequency. We haven't had those types of cases yet. Ours have been more chronic cases, which is duration over weeks, right? But all the people that were getting on for more chronic stuff, they're all turning a corner.
Yeah, we had 2 wins. Paul, he's had 40 years of chronic low back pain, and he did his 15th session in about 4 weeks. He was real committed to, he's like, I want to do this. So he was coming in pretty much every day for the first week and then kind of filtered down from there. But he said he had the best weekend he can remember as far as like just stiffness in his low back. And he's like honestly coming in antalgic pretty much every visit. Yeah. And I'm trying to adjust him and do flexion distraction. And we got this table, and he was one of the first ones to, take it on.
Amazing.
And no promises. 40 years of low back pain. Right. I'm not going to say like this is going to be a slam dunk for you, but he has noticed a improvement and wants to keep doing it. And then
and I'd say the majority of cases, to answer your question, like how many visits does it take? Because it's not just like a one time. Like you're going to be feeling amazing after one visit, right? Because it's we could talk about like the design of the table and how it's designed to pull and whatnot. But I'd say if you were to take like a bell curve of treatment amount per case, it's probably anywhere between 12 to 20. 12 to 24 is majority of cases probably fall into that category, and that that can be anywhere between 4 to 8 weeks too. So that's a majority of it, but it kind of depends on their goals, their exam findings, if they're having other symptoms like into their legs, or MRI comes back and it's pretty severe herniation or bulge or whatever it is. But if they're noticing objective or even subjective, so what they're feeling or what we're finding, if they're seeing improvement, then keep going. Right? It's like an exercise program. Like you keep stressing those tissues in the right way, like you will give that disc the opportunity to heal, right? Because these discs will heal majority of the time, but you have to give them the opportunity. And part of the disc too is it doesn't have a great blood supply, like a muscle, right? So you get people that are like, oh, I sprained hurt a muscle, did this, like 4 to 6 weeks, within a couple of weeks at least, like it should be feeling better. Where this is more time because of that poor blood supply. And
would SoftWave help bring some blood to that area? So like complementing Have you guys had some cases, where that other peak of the triangle is being used for decompression, and how does that look? Enough data yet to say like, oh boy, that sure helped speed things up? Or
Yeah, not. We've had success even before decompression with just SoftWave on disc injuries, right? Supporting the surrounding tissues, just flushing out the inflammation, and starting to get blood flow into the area can do quite a bit. But those are the patients where we can also get away with adjusting them, right? Sometimes when somebody comes in with a disc herniation or disc bulge, there's not a whole lot that we can do as far as like a manipulation standpoint, just because sometimes those discs don't like to be put in that position, like whether it be twisting or tilting or whatever it is. But if you can decompress, if you can axial decompress the spine, so lengthwise, a lot of times that's gonna be a lot more pain-free.
As far as the adjustment goes, we usually adjust around that. Prior to decompression, we'd be like, let's check hips and pelvis. And
hips is a big one. Because if they're getting it, most people are sitting, right? If they're sitting, their hips are going to be dysfunctional a lot of the time too.
So is it better to, case by case maybe, but is it better to get an adjustment and then decompress table, or does it really vary? Right in there, just honk away.
Some people recommend not doing any adjustments in the area that you're treating with decompression.
We're not into that.
Well, I mean, but also
to a point.
Well, no. Like if we get somebody in a position that we're going to adjust their low back and they do not tolerate that, like it hurts their low back, it's traveling into their glutes or their leg, like we hit stop. Like we don't continue. We use that as an information, as a diagnostic, right? So those are some cases, like if somebody comes in and it's like, you're in rough condition, like get them on the decompression too.
And then I would say the default, or not default, but the other piece that you can add to that, some people I would be a little bit weary to put on a decompression table just because they're in such a heightened state, like the flexion distraction table that we have. That's a nice segue
sure,
to test things before getting somebody on a table, because some people can't tolerate being on their backs even.
Well, and the typical treatment time is anywhere between 20 to 25 minutes, right? So
on the table,
for them to be in that position for that long, if they're really acute, it might be rough. So we can use the first, like using the flexion distraction table that we have in a shorter duration, just to pump out some of that fluid,
get some motion in there,
and just get them feeling better so that they can tolerate being on their back.
I would, like we say with everything, it's a tool in the toolbox. So if someone's really acute, sometimes I'll just default to flexion distraction, SoftWave, maybe a hip adjustment.
But on another note, another case I had come in today was a patient that had some neuropathy in their feet. And we were discussing it, and we were just talking about like if SoftWave can help, which it can with neuropathy, just to get blood flow to the nerves, like further away from our spine, so that those nerves get the oxygen that they need and the nutrients that they have to function and whatnot. But through the examination and doing some light flexion distraction, just gapping, just getting some movement in her spine in a really gentle way. Like she had noticeable change even getting off the table.
She got off the table. She's like, that can't be true.
No way. She's like, no way that can make a change in my feet that fast. And I'm like, yep. I'm like, guess what you're doing next time? You're getting on the decompression table. Because if you do that over 20 minutes, like that's going to be very beneficial. Just the time under pressure, right, of decompressing that. So it's cases like those that now we have that as a tool. I would say, because the cool thing about the table is it's computerized. So basically, the way we set somebody up is we strap in their pelvis to stabilize that. That pelvis harness attaches to the table, which has a sensor right at the table that can track tension of the patient, tension of the table, and then we have another strap that goes underneath their rib cage. And the table angle can deviate a lot of different ways. It can move, it can angle up so that we can target a pretty specific area of the spine.
Okay.
But also with our table, which is cool, is we can treat somebody not only on their back, but also face down. We can also add flexion, lateral flexion.
Oh, wow.
So say if somebody has a disc injury, like a disc issue on their right side,
Yeah.
right?
Right.
A lot of times, not always, and we find this out through the examination, is if we move their legs opposite or create flexion away from that can help open up that space.
Wow, you really can target it.
Right?
That's
So we can
amazing.
target it that way.
Yeah.
Some people are opposite, right? You actually go towards that side and they'll get relief. We had a couple patients like that where it's like, hey, let's just try it, angle it, and they're like, oh yeah.
Well, in SoftWave, it's a similar thing as far as like getting to the exact target point, right? You got to move around, you got to kind of explore it and find it. But SoftWave, maybe talk about that too, of how you have a similar therapy technology that allows you to get really specific.
Yeah,
Yes.
SoftWave will target the tissue that's injured. So you'll go over an area where someone might have a right-sided low back thing, and they're like, it feels like it's right here. And then we search the area, and it's like, oh, it's actually piriformis that's lighting up a little bit more,
Yep.
and that's causing the pain down your leg, perhaps. You know,
Yep.
that's
And
SoftWave's
sometimes-
nice for tracking those types of things.
And it can be in combination, right? They can have a disc problem, a disc ailment in their low back, and then where that nerve travels is down into your glutes. So you can have like two things going on at the same time, where the spine's not acting how it should, and then downstream where the nerve crosses over that piriformis or through it sometimes, like if there's inflammation there, that can also create the radicular pain into their legs, like sciatica.
I just had that with John today. I adjusted him, and his foot kind of turned on fire. He's like, what was that? I'm like, well, let's check your knee. And he told me he started running a bit more, and he saw Tyler Kleinhausen, and he noted that his VMO was shut off, but there was something going on with his lateral knee, and I did SoftWave on his fibular head and back into the like popliteus. And he's like, oh yeah, that hurts a lot. I'm like, yeah, you have like nerve entrapment in your low back, piriformis, and peroneal nerve are all getting lit up. So
Jeez.
But yeah, the table's really cool because we can kind of target a specific area, and that's where an MRI is useful. Because then
X-ray
it's just
too,
like,
we could argue that, you know, a simple X-ray can show us, but it's not going to show us the soft tissue.
it could show us like degeneration. So if you look at that poster behind you, like where you see the extruded
Lowest.
disc, the middle, where the little red herniation, go to your left.
And
Yeah. So if you go down from there, like a thinning disc or
Lowest.
degenerated disc,
Yeah.
that's where people will hear the term like disc degeneration.
Sure.
Is where that disc is losing its normal hydration, and then
You can see that
The bones
on-
get all bumpy
you can
and
see
stuff
that,
around
yeah. And that's an arthritic change that happens because your body's in a mode where it's like, hey, this area is stress. We should build more bone to stabilize this.
Wolf's Law.
Wolf's law.
Interesting.
Bone under stress will create more bone.
And that's actually a stabilizing
It's a stabilizing
mechanism. So that's why you have people like go through like decades of low back pain, and then when they get older, it goes away because
'Cause
their
you got all
bones
the
kind of
bone there,
fuse
yeah.
and
Just
it can't
kinda fuse.
irritate that
Right.
tissue around there,
You lose the mobility.
which
and-
is not what we want, but it ends up working
Yeah.
out for them. But
'Cause-
like,
yeah.
go ahead.
Because you lose you were saying it, but you lose the mobility of that joint, and that's what your disc does. It's a motion segment that allows those two bones to be able to, move side to side and twist. And if you lose that, it's just a limitation of matter.
Game
where you
over,
just
man.
Game
Yeah.
over.
It's stabilizing, but that's your body's response to that injury. And a lot of times those can be from something that happened decades ago.
Right.
Right? Like riding a horse as a young kid. You just have constant repetition, irritation of that. And then over time, that disc dehydrates because it needs that pumping mechanism to get
Yeah.
nutrients in and out. And if you lose that, that's when your body starts to say, hey, let's stabilize this segment.
So for those people that, and we talked about this when we did the SoftWave episode, but that just they're in this helpless point of like, well, surgery is imminent and I got to do this. And, I think you guys have talked about, well, maybe, but let's first try SoftWave. Let's see what we can do with SoftWave. And does this kind of fall in that same category of like another tool that we can do to avoid surgery maybe altogether or put it off and see what we can do?
100%.
I think if you, well, go ahead. You speak because I think you're on something
Well,
here.
a lot of times, if somebody has disc injury and they were to go see an orthopedic, a lot of times they'll send them through 6 weeks of PT, right? It's conservative care, right? And they utilize PT. Some cases, PT can actually make it worse, right? If you're strengthening an unstable and not just unstable but damaged part of the spine, sometimes, not always, but sometimes that can make it worse. That's where like decompressing that spine and just getting space in that disc for it to have the opportunity to heal, that's where it can really go well together with, you know, with SoftWave, with PT, with everything else. So yeah, I mean, surgery should be last resort, of course, especially spine surgery. Spine surgeries are not fun.
What about the neck, the upper spinal area? The decompression, can you guys use the table for that too? You guys talked a lot about lower lumbar and everything, but what about neck and people with neck stuff?
I can't believe.
Does it help
so
congestion?
It might, yeah.
Maybe. Actually, it doesn't.
It's a decongestive therapy.
Before we answer that, I would say if someone's been told they need spinal surgery, it might be warranted. If someone's in that situation where they're trying to figure out, well, is that the right decision or not, you could do this decompression and it could set up your surgery for more success too. You know, some people might say like, I might as well just get the surgery then. Well, if you can tolerate decompression for a stint of time to kind of prep the tissues, it's like prehab before surgery. I could definitely say that's probably something you want to do, because if it helps and your symptoms go away, that's great, but you're still doing, it's kind of like SoftWave too. We have people who do SoftWave for like a hip or something that's, ends up getting replaced. It's like, well, all those tissues are better now. Prior to the surgery, and you can recover quicker, more quickly. So I think that's something too, where it's like if someone has the time and isn't in dire straits, like to do something like this is not all for naught. So, which like you have people who come in with like ridiculous shoulder stuff where like hands are going numb and tingling. Well, if you could do an X-ray or MRI and see that there's some disc tissue or some degeneration in there, it's definitely worth a shot doing some decompression on top of adjusting SoftWave. You can throw everything at it and see similar results.
Another common thing is, I've heard this, but they're like, what about just like an inversion table?
Upside down.
Just traction, right? And like traction.
What's the difference? I think that's important.
So technically it's called non-surgical spinal decompression because there is like a process, there is a technique that surgeons use that's called decompression surgery, right? So that's where that name comes from. But
they cut these things off and decompress the spine that way.
Or just like releases
it.
Cut off at the pedicles here and lets that central canal breathe.
Do they add hardware to it?
Not necessarily. They can do like a laminectomy. My dad had a 3-level in his low back. They took out 3 of those pieces. And that helped. But now fusion is a thing. If his low back goes even worse, they'll just tie it together and make it not move.
Which is a whole nother thing.
And then once you do that, you can't really do decompression on those areas. Because same with adjusting, you're not supposed to adjust it. So for a patient who's got any hardware in their spine, you can, depending on the area, you can do some traction, but if it's specifically in the low back, like L5S1, we're not supposed to do any decompression on it. So
but back to like traction. It's like traction therapy. Like if you're to do an inversion table, like you're gonna traction is just movement of joints the long way, right? So if you're doing like an inversion table, you're gonna get a lot of your joints. You're gonna traction a lot of your joints, right? So
all at the same time.
A gross pull.
Sure.
Kind of full body, right?
Sure.
Where a table like what we have, you can focus on a really specific area and target that area.
Cool.
So they get more effectiveness. And in fact, sometimes if somebody has like an acute disc injury and they're in pain, number one, how the heck are they going to get on an inversion table? Like, it's going to be painful enough, right? But sometimes what can happen is as you pull that injured disc, the muscles and ligaments around them, they have sensors. They have little receptors in there that respond.
Yeah.
And, that's why a lot of times people have spasms with an injury, is because those muscles are responding. They're trying to, like, basically make a cast so that you don't further injure. And if you set those off with too much tension, sometimes that can increase the disc pressure.
Because the muscles will tighten up.
They'll tighten up. So when we talked about decreasing the pressure, creating a negative vacuum, like a lot of times what we're talking about is the disc pressure, right? So if you have pressure down, that's a positive pressure. As you pull apart, that's a negative pressure. So if you have
negative,
yeah, exactly. So as you compress that more, that could possibly make it worse. And then if you're stuck there, that's not a good thing either. But I'd say general population, if you're doing full body traction inversion table, it's probably not an issue.
Yeah.
Right? Just to kind of mitigate some of the effects of gravity that's working on us all the time. But with that too is, like, you asked the question of frequency, like how often, right? And people are in here 30 minutes to an hour tops, right? I mean, think of the other rest of the day.
Right.
You got to talk about things that they're doing. Like, are you still sitting 8 hours a day? How are you sitting?
Yeah.
Right? Like, how are you bending over to pick something on the ground?
Yeah.
Like, those things all matter, because if you have that repetitive stress to the disc, that's still going to have wear and tear on it.
Yep.
So those are kind of the biggest things with, like, traction and decompression. Decompression is more focused on the area.
How do you speak to your patients when they come in and they're maybe they're indicating that they could benefit from all three of these things?
Classic avatar is the aging golfer who notices, like, their spine feels very stiff after a round of golf and they're having pain with it. They might have some neuropathy or some leg symptoms associated with it. That tells us that there's a decompression of that disc, and the nerves that are going out are affected by that loss of disc height. That's kind of a classic one.
But yeah, some symptoms, if they have pain, increased pain when, like, sitting, or just that compression, right? Sometimes people have it, symptoms are worse in the morning, because part of it is your discs are typically a little bit more hydrated when you wake up in the morning, right? That's why they say, like, you're taller when you wake up in the morning. So that increase accumulation of fluid when you wake up can sometimes push past the threshold of whatever disc symptom they're having, and can put pressure on that nerve too. So let's say if somebody comes in, they're like, yeah, it's worse when in the morning or when I'm sitting, or if it increases when I touch my toes, those types of things. I mean, the typical, like, diagnoses that we treat are like herniations, bulges, stenosis, like we talked about. But there's a lot of other signs that they can have. Right. And it doesn't necessarily always have to be back pain. Right. Like, if, I don't know the percentages on it, but there's a decent percent where people will have a low back problem, but they won't have low back pain. Right. It might be into their glutes or into their hamstrings. And, like, if somebody comes in and they're like, man, it feels like my hamstrings are just, like, on fire all the time. Right. I try to stretch them out. It doesn't help. And if it's been going on for weeks, it's like, yeah, it might not be a hamstring issue, right? Because that should heal.
Same thing, like shoulder stuff. Like, the back of my arm is, like, feeling on fire. My thumb or pointer finger are going numb, or my hand is, carpal tunnel, essentially. Sometimes it's not carpal tunnel. Sometimes it's up the chain, neck, shoulder, elbow, and wrist can be a problem. But if we start at the base, at the root of the problem, the nerve roots, that can be a big helper for people. And I would say if someone's received conservative care, whether it's chiropractic or PT or just rehab in general, spinal decompression is not a lot of people have done it. Like, as a clinician, there's a handful, like your clinic had decompression, but it's not everywhere. So the people who have done the standard stuff, I see my chiropractor, but my symptoms aren't relieving. Well, that might be a sign to try something different. Right. And it's nice too because you should know pretty quickly, handful of decompression sessions.
So there's that like level of trust and commitment that you really have to.
Yeah, we
as a
need
patient.
patients who, if you're just wanting a tune-up, decompression isn't for you.
Right.
No,
And we're not forcing people into it either.
Right.
Because people do feel better with just an adjustment, and you can have a very successful practice with that. I would say for myself and Dr. Zach, perhaps we're at a point where we're curious about other therapies and we're curious how we're integrating them into the practice.
So with the table, a lot of times people may not even notice a difference, like the first session especially.
Right.
Right. A lot of people will be like, yeah, I don't feel anything.
And
like
that's designed,
It's designed to be like that, right? So
Okay.
it's not necessarily like, yep, one session's going to get you there. We start slow and then we build up.
Yep.
With the amount of weight and time and all those variables too.
Yep.
And if you go too fast, too quickly, people feel it and they go, that was too much.
Right.
It's not more is better.
Right.
It's in the sense of weight, but the amount of times that you're coming in, that's what's going to help that disc. And the other thing with difference with like traction and decompression is traction is it's a constant pull.
Right.
Right. So it's just pulling.
Yeah.
Like with the inversion table.
Inversion
Right.
table
The
is
gravity's
a constant
constantly pulling.
pulling versus a decompression. It's more of a pumping effect.
Cool.
So it'll pull, it'll relax, it'll pull or relax to help create that pumping mechanism.
Cool.
To create that positive and negative pressure in the
Yeah.
disc to help that tissue,
Yeah.
help that disc open up a little bit too.
Yeah.
So it's that more of just that in and that on and off.
That
of
repetition
pull,
there.
That repetition
That's
while they're
cool.
on the table too, versus
Yeah.
just a stagnant, steady pull.
Yeah.
That's
That's
another
super
big
cool.
differentiator with the two tables.
Is there a vacuum? I mean, you said that before, but is there like a nutrient sucking vacuum effect with that pulling, or is that too?
The osmotic pressure.
The osmotic pressure will
Okay.
help bring in nutrients, blood flow to that disc.
Maybe that's what you should talk about. The essence of the clinic is sort of, hey, we want to put you through as many diagnostic testings that we can to really pinpoint where the issues are at, and with these three points, you can really do that. Versus another clinic that's we hang our hat on decompression, we hang our hat on SoftWave, we hang our hat on traditional chiropractic adjustments and manipulations. Like, whereas Midwest Chiropractic seems to be like, yes, and we could do all three of these. Why not? If we have all three of these tools, why not see which one
Leverage the
where you
I think
fall.
synergy.
I think it's good. Just as our job is to help educate patients on like the therapies that are out there that are going to benefit them.
Yeah.
And if somebody comes in, a new patient, and they're like, I don't know, I need a chiropractor. Like new patient that we were talking about before, like he's never seen a chiropractor before. And he's in his 80s, right?
Yeah, Joe.
So we're talking about it. I'm trying to like, hey, here are the options, right? And I include, well, we talked about decompression, but we kind of ruled that out, obviously. We talked about SoftWave. We talked about some of the flexion distraction adjustment styles that we do with his neck. And then also go with the other options, like, hey, here are some other routes. We don't do this, but, like seeing somebody to possibly do like a steroid injection or some topical pain relief, right? Like those are options that I don't want to like not tell patients about,
Yeah.
right? Like we don't do that. Like if it was up to us, if it was our choice, like let's do the SoftWave and decompression and adjustments, right? Because that's where we see benefit. But I think my point being is when people come in and they think they need an adjustment or they think they need decompression even sometimes, that you can help guide them better to their care and be like, yes, you have this as, and we can teach them through our exam too of like, hey, this maneuver I did on you and it increased your pain, that's telling me this.
Right.
It actually tells me that you'd probably be better with this therapy versus that therapy.
Right.
Where before, we had adjustments. Like when we first started, we just had adjustments, right? And it was, certain cases we would have good success to some extent, but sometimes we hit a roadblock of like, you need this,
Yeah.
right? We do a trial or now since we have this tool, we can better guide them and better educate them on like, hey, here are the other therapies, and this is why I think it'll help you more.
Like you said, your job is to educate, right? It's like your job is to teach people like this is why we're doing it, and this is why we think it will be helpful. It's their choice with whether they want to go forward with it or not. But
to your point, like we're not trying, like, well, you said this, like we're not pushing people to do one or the other.
Yeah.
Like they each have their costs. They each have different costs too, right? It's like this isn't free, obviously, but if we can guide them to what's going to get them the most success in the shortest amount of time and longer outcomes, like now we have that.
Yeah.
Stack the value a bit.
Just stack it, right?
Because people can do one thing at a time too, but I think time is a huge factor for people. And if we're not
Talk more about that, because I think that's super important for people.
Yeah, I think our default is to get people better. You know, if we're not seeing a difference in 2 to 4 weeks, then we gotta figure something else out. Whether it's, you know, we have a conversation about cost and frequency and all that stuff, and if there are some limitations there, we obviously have to work with people and meet them where they're at in those departments. But I do think if people are committed to coming in and trying it out and giving it a good old college try, as they say, if we're not seeing what we want, we'll tell people pretty quickly.
Yeah.
Because there's enough clinical examples in our tenure as chiropractors where it's like, oh, you have a torn hip labrum and that's why you're not responding. You know, we can give it a try, but if it's not working, we push people out to, you know, imaging or other providers fairly quickly. I think nutrition, I mean, there's a component that should be like with decompression therapy too. You know, if you're not hydrating yourself, just like with any other type of thing, there's people who come in and they're chemically deprived, whether that's, you know, they're smoking or drinking too much or not eating the right thing, or on pharmaceuticals that are messing stuff up. But that is another thing too, a factor for people if they're not willing to change their nutrition.
It's limiting.
Yeah.
It's limiting factors, right? I mean, it's a mutual effort. Like we're going to do what we can here, but you got to be doing the other stuff well too.
But there are some patients where it's like, you smoke and you're dehydrated. You're going to have a harder time recuperating.
I mean, if you're a smoker, your prevalence of having a disc injury skyrocketed.
It's 1 million.
It's high. Like your likelihood of having some sort of disc from being a disc injury, from being just a smoker.
Drying out the tissues.
Sure. Hopefully that sheds some light on decompression and the Flux Capacitor of Midwest Chiropractic and Wellness.
What are the 3 points again?
Yeah, the trifecta, the Flux Capacitor, I'd say the top sprung is adjustments, and the bottom 2 are SoftWave and decompression.
Yeah.
And we leverage them to certain times when
you
people
can describe like what each of them do.
Yeah.
Adjustments, get things moving, gets the joints mobilized.
Makes sticky joints unsticky.
And the other point too is the pain signaling. I think all 3 work at their own angle. But like if you get adjusted, you feel better after it. If you get SoftWave, you should have less pain, and decompression, you should feel some pain relief with it too, with some caveats alongside of that. Yeah.
So that kind of
triple threat at Midwest Chiro.
Well, that's the thing. Come talk with us. If you have questions,
give it a try.
Let's talk about what the best therapy is for you, and we can go over options. So, with that being said, that's a wrap.
On the tap.
Boom, boom.
Cheers.
Nice guy.
This is a house of learned doctors.